Okay, so the first thing we're going to talk about is I've got a picture up here of a gentleman who's having probably a very bad day. All right. What do you see?
Well, lots of tubes.
Okay, we see lots of tubes. You're right, there are a lot of tubes. He's actually, yeah, lots and lots of tubes. Okay, so let's start labeling and naming some of these tubes. What do we got? Okay, so we've got, well, I don't know how my black will show up. Let's see. Let's see if green will show up. Okay. Okay, so we've got an NG, and it actually looks kind of like, I don't know, that may have been more of a NG or a Dobhoff. Have you guys heard of Dobhoffs before? Yeah, they're just really pliable and small. They're really nice and small, so they're really bendable. Okay.
Some of us can't get it to download.
The pictures?
Yeah, I feel like you
Okay. I was gonna say when I like held on to it for a while, it was like that's how I had to do it, like touch screen. I was like, okay, let's see. Like I said, normally I don't even share my pictures. I just leave this go. But I was like, let's see a picture. No worries, no worries. So Dobhoff. What's the difference between a Dobhoff and an NG? For people that are working on getting this download, I'll let you guys get your thing. What's the difference between a Dobhoff and an NG?
Dobhoff is smaller.
Okay, smaller. Yeah, it has that weighted tip versus an NG doesn't. What's the purpose of a Dobhoff versus an NG? Yeah, Dobhoff. Yep, keep going.
And NG is the like removal.
Yeah. So NG can do both, right? It can suck or it can feed. But Dobhoffs are going to be only for feeding because they're so small. If you start sucking with them, they'll collapse, and so they're only going to be meant for that feeding process. Okay. So we won't probably get that detailed on the test, but I just want to give us time. Everybody kind of got situated and adjusted, or we see a couple people still touching and pucking, and I want to give time for people to adapt because I know. I will also tell you I'm not a very good A-type person, so if you are a strong A-type, I'm probably going to make you struggle. Okay, but it's good. We gotta learn how to work with different people, right? All right, that means me too. Okay. All right, so we've got NG Dobhoff, right? So that means we know he's being fed, right? Because we can see that he's got a Dobhoff, we know he's being fed, which is important for our patients in the ICU. Okay, what other tubes do we see? All right. I was like, let's go for the big obvious one, right? Okay, so we've got an ET tube, so we can see that it's not a trach. So we've got an ET tube. We got a whole lot of tubes hooked up to him here that are all going to the ventilator. Okay, so ICU nurse, you'd want to follow those back because I'd want to look at those ventilator settings, right? What ventilator settings do we care about? So yeah, we're also going to pull in from Monday. PEEP. Okay, what numbers on PEEP do we like? 5. We like 5. That's our happy space, okay? What ones are like, oh, we're probably not doing so hot space? 12 to 18, 20, we're popping along, right? Like, those are when we get kind of sketch. Like, 8, I'll see people at 8 for a while, stuff like that. But when we start climbing, PEEP going up is not a good thing, okay? All right, what other vent settings do we know about? Okay, so we got our PEEP. We got FiO2. What's FiO2? What's that mean, though? Right? We always know the big words, the big fancy words. What does that actually mean? It's a percentage of oxygen, right? Let's keep this simple. I love when people are like, "Oh, ICU," and I'm like, "No, dude, let's keep them simple, right?" Okay. So we're gonna be looking at this vent. We're gonna be looking at the PEEP with FiO2. What are we all breathing right now? 21% is room air. So anything kind of above that. Different hospitals have kind of a different baseline. Some will go down to about 25 is the lowest they'll go, some 30. So you just have to work with your facility on where kind of is their low setting. Anybody on 100% FiO2, I'm pretty concerned about, right? And then just you're watching in that titration of, we might have to turn them up a little bit as we do stuff with them. We might have to turn them down a little bit, okay? What other settings do we want? Huh? Okay, our respiratory rate. What does that tell us? What do we want for that?
How hard they're working.
Okay. Not how hard they're working. We're gonna have to probably look at them for that, right? But what does it tell us? Okay. So if they're on the vent, depending on, so this is where that assessment, just having the number doesn't give you a whole lot of information. Respiratory rate is 16. I always love that when I see that one charted all the time. I'm like, respiratory rate is 16. Fantastic, you didn't count. Okay. But so respiratory rate, you'll see it set. Usually it means they can't go below that. What if the respiratory rate is set at 16, but they're breathing 22? They're taking 6 extra breaths, right? Yeah. So depending on their setting, so mode is also a one we always want to pay attention to. But like we'll set it, sometimes we'll set it real low. We'll set them at 10, 12 respiratory, especially if the lungs aren't our issue and it's another issue that we're really worried about. They are going to breathe over the vent. Now, depending on what's going on, if I have them paralyzed, they shouldn't be breathing over that vent, right? They should be breathing straight with the vent. I don't have them very well paralyzed if they're not, if they're breathing over it. If they are just on some sedation, right? They might be breathing over that vent, just because their body's going to make that breath sound or make that chest rise and fall. Okay, so PEEP we want about 5, FiO2 kind of 30 to 100 is our range. Respiratory rate, it's kind of whatever we set it to. All right, sometimes we'll have to really get people oxygenated, so we'll kind of set that rate high, right? But we might shrink their tidal volume. Maybe we want them to take lots of little quick breaths. Maybe we want them to take big breaths. So what helps us with that, whether they're little quick breaths? Yeah, our tidal volume. And I don't know why they do TV instead of VT, but whatever. It's like tidal volume, I think they chart it as VT. So it just kind of depends on what facility you're working with. But if you see that, it's not about the TV on the screen. It's about what we're taking in for our lungs. That is done with a measurement of height, weight, all that kind of stuff. Respiratory therapy, and the docs are going to figure out what they want based on what's going on with that patient condition, ABGs, all that kind of stuff. All right, I don't usually mess with those. Okay, so we got that ET tube.
Aaron, what rates do we need to know, like normal rates for the tidal volume?
I mean, we know about around 400 is usually kind of, some people are real low, some people are real, like your bigger, taller people, they're going to have bigger, taller numbers, right? Because they can take more volume. Your little 80-year-olds who like, the higher the volume, it's just like the more volume, it's the more literally the more volume of oxygen we're expanding those lungs. So if you have somebody that's like 6'7", they may have a really nice big size tidal volume. That may be their baseline. Depending on your patient, I've seen patients as low as like 200, 220, something like that, where we've set them to that because they just can't get those lungs open. Okay, again, not going to be something that we mess with, but just we have to look in and you can understand like, ooh, we've probably got some lung disease issue going on here. Okay, because they're just not, or you got that little bitty who's tiny and takes, and then like your babies, they're going to have really tiny tidal volumes, right? Because they don't have those big lungs. Okay, so that's kind of a review from the ventilator stuff. What other things we got going on with this guy? It is not a pulse ox, but good that you're seeing it. It's not. Huh?
EEG.
It's an EEG. They call him is it a Biz monitor? Okay. That's the brand of it. That is, so this person, like just by looking at this, I can tell this person's, we're pretty extensive in our issue of what's going on with them. If I've got somebody on a Biz monitor, which is the monitoring, we'd probably have them paralyzed and sedated, right? He's obviously, we want him sedated, okay? So those are the things, sometimes you'll hear people say train of 4. That's where they put the little electrodes and we're looking to see, and they'll say they have a train of 4. It pulses 4 times, and we usually want to see a 2 of 4. It means we want to see 2 twitches, even though it's giving 4 pulses. Okay, so those are when we're starting to look at our paralytics. What's the difference between a paralytic and a sedative?
Paralytic means you can't move.
Yep, it literally paralyzes, right? A paralytic is going to paralyze you. all right? When we had patients that were going through COVID, we did a lot of paralytics. I think we used it like water for a long time. I'm not sure if they're doing it now, like what that one changes quick. But our patients that, like when Lindsay talked about cooling people, we do paralytics because we don't want you to shiver, okay? I've done paralytics on patients that have seizures. We want to paralyze them because we don't want them having that seizure. We need to paralyze them so we can intubate them and get them comfortable.
I know when I'm doing RSIs, he's dropping sucks on them, but do you use sucks for like a long-term paralytic, or how do you
No.
use?
Good question. Hold on to that question because I've got the next hour will be timeline of a ventilator, and we'll talk about the different drugs we use while you're on a vent, and to intubate. So,
Are you using that EEG monitoring then to
Mhm.
determine if he's sedated enough?
if he's too awake, it's you. Because how are we going to tell if you're paralyzed? Can you squeeze my hands? Right? Can I do pupillary responses? No. Any of those cranial nerves that we really focus on, we can't look at. So it tells us if their EEG starts climbing, it means they're not very sleepy. So yeah, we're looking for the sedation, but it's because we've paralyzed them. Okay? So this is the horror stories you hear about people waking up in surgery. So sometimes you'll see people just coming up post-op with like a sticky goo on their forehead. They probably had one of these on, so they were watching it to see if they had them, because you're usually, a lot of times we use paralytics during surgery because we don't want you twitching during surgery when we're cutting you. We like you to be still, right? There's enough moving parts in the human body. We want you to be as still as we can get you.
I was gonna say, when they're paralyzed, they can still feel pain, they
Yep.
can express it, correct?
Correct. Yep. They can feel, see, hear, everything. Redonda Bott case, she gave a paralytic without a sedative. So that woman knew she was dying. That's why that case was like so hard for a lot of people, was that woman suffocated because she couldn't move her diaphragm and her lungs and all that. But she was awake and knew it. But we couldn't tell she was awake because she's paralyzed.
So kind of like sleep paralysis almost.
Yep, so if you see somebody with that on, we're looking, usually we've got a paralytic on board and we're looking for that sedative property, okay? That also lets me know, if I see that on, lets me know you're pretty sick. Because I always tell people the more wires and tubes we have on people, lets us know that you're more sick. In fact, I just told a family yesterday as we're taking out an art line, I'm like, one tube out. We got one tube out, we got about 10 more to go, right? So one tube out at a time, all right? Okay, so what else we got going on? We got a whole lot of pumps. I don't know if you guys have seen these types of pumps, but those are my favorite. These are the Alaris pumps. One pump, they call it a mama, can run 4 different drugs. So you can see how we've got, you've got 1, 2, 3, 4 different meds running through that same pump. Okay, the tubes aren't crossing. It's just the pump, the system that they're running through. Okay, this one's got, it looks like he's got, let's see, 4, 8, maybe we can see 10 different medications going. Alaris pump? Yeah, it's just a different type of pump. You guys see I think what do we have? Are they barbs or something at Methodist? I can't remember. Yeah.
Bergen uses the.
Bergen uses these, yeah. CHI, I think, just switched to them in Lincoln. We used them in Lincoln. So, but they're really nice because you can run different meds through. The most meds I've ever had running at one time is 13. So, what becomes an issue then? Huh? Access? Why does access become an issue?
Sometimes we can't put the same meds through.
Yep, compatibility, right? So compatibility becomes an issue, and so we'll get these patients and we'll have to really, it becomes like a fun Sudoku mind mapping puzzle of like, what do I have to hook where? Because I can do these certain things together, right? But even if I can do like a lot of our cardiac meds together, think how far out they get from the patient. I don't want epinephrine way out here, right? I want it as close to the patient. So any of our cardiac meds, any of our pressors, any of that stuff, we want as close to the patient as possible.
So how many access ports does that patient have?
Let's see. It looks like,
Does it look like he has an IJ with the 3?
yeah, it looks like here. Looks like about here he's got probably an IJ. So a right IJ, which would probably have three access. That's what I tell you guys. Don't ask ICU nurses to start IVs. We have central lines. Right? So we have like, if I have to start an IV, my IV experience came from my oncology days. They have really crappy veins, so I can start IVs really well. I love starting IVs, by the way. But most of the time we have central lines. So every once in a while we'll have to get a peripheral just because we don't have enough. We have compatibility issues, and we have to start adding more access to them. Okay? We can start them anywhere. I can start them on a foot if I have to, thumb, whatever. But, okay? So, he's a pretty sick dude. Right? He's also, it says, I love this back here. Patient's ICD is turned off. What's that? Okay, it's not just a cardiac monitor. It's a shocker. It's a defibrillator, right? So we have this patient's ICD turned off. So I don't think he was necessarily a super healthy person probably coming into this procedure. And those are things. You will see stuff taped up to walls. We will tape stuff up to walls, like keep head of bed at 30 degrees. If there's something, especially like our head trauma patients, you'll see stuff like on the wall that says, you know, don't, or if we've got like LVAD patients or something, do not do CPR. You'll see those. If there is a note above the head of the bed, it's usually a really important one. Okay, and so we want to make sure we're paying attention to that. All right. See, I already got off my track.
What about
Huh?
Oh.
What?
Oh, I thought that was the sign.
Oh, no. This is just my notes.
Oh.
Sign-in sheet's coming. Sign-in sheet's coming. We're good. All right.
What about the, what's the thing by his eye?
Which
Is that just another extension of the EEG?
which one? The gray one?
Yeah.
Yep, that's from the EEG. Then you've got like, it looks like his propofol's coming through on the IV. If you notice, right here, I know it's kind of hard to see. He's got a sticky note on an IV tubing. Why would that start to become important? Yeah, to know what's going through each tube. Okay, like I already said, I'm not an A-type. I am not OCD about much. My IV lines are the one thing I am super OCD about. Because if he goes down and they go down quick, I need to know what line I can disconnect. I need to know what line I need to start shoving like epi and all that stuff through. So those lines, you'll start seeing those, your ICU nurses, they get very particular about their IV lines. And then we have to take them down to CT scan. And it's always at 6 a.m., right? And so then all the day shift nurses come in and they're like, oh, your IV lines are a mess. And you're just like, I just got back from CT. Give me a minute, right? Because they become, anybody have necklaces that you like can't get untangled? That is what it becomes, is like they're twisted, we've turned the patient, they have an art line, they have all sorts of different lines. So we have to know what we can unplug and what we can't. He probably has an art line and we aren't seeing it. All right, so this is a pretty sick dude. All right, and there's gonna be a lot of challenges to his care. Okay, what kind of complications? See, this is why I don't do, I wouldn't even go on this way yet. But we've talked about him so much. What kind of complications would we anticipate? And not just for him, but for other ICU patients. Yeah. Where's that pressure sores going to be? Okay, so we got coccyx. Where else? Yeah, anywhere there's a tube, we start running into pressure problems, right? So if we've got an ET tube in and it's been pushing against their lip for so many days, or the back of their tongue, or the roof of their mouth, that all causes pressure issues, causes pressure sores, okay? You can see they've got like a washcloth kind of wadded up by his head. That may be to keep his head going. It may be because he's a drooly dude, but it also could be just to help hold some of those tubes off of his face. Okay, because there's a lot of weight on him. So pressure sores become a huge issue for patients. NGs will get pressure sores on their nose. I don't know if you guys have already seen those kind of come through. Art lines will get pressure sores like on the art lines because we have to keep them tight, and then we have them in that wrist brace and all that kind of stuff. So you'll see like they'll get pressure sores like right around their thumbs and stuff like that. So pressure sores don't always just come from laying in one space. It's also the tubes. That's one really important reason why we move the ET tube from side to side every 2 hours or so. You'll move it, usually side, center, side. And it's just so we keep that so it doesn't always get on their cheek. They can get it on the back of their tongue, which we don't ever see, which is sad because then they'll get extubated and then they'll have it. And you're just like, oh, sorry, but we saved your life, right? So, okay. What other complications?
HAI,
Huh?
HAI,
HAIs, what are you talking about?
healthcare acquired infections.
Okay, so we're just gonna call it infections. Because, yep, we've got lots of tubes. And how's our immune system right now? Probably pretty low, kind of crappy, right? So we've got lots of tubes that are, and remember, like, anytime we give a tube, I think of it of a ladder for bacteria to get in. So ET tube, that's what, a ladder down to the lungs for infection. Foley, ladder up to the bladder, right? It's given that bacteria time to get there. Lots of tubes. VAP, we're just gonna go call that one out specific. Ventilator assisted pneumonia. That's when we get dinged for a lot when we have problems with patients getting it. What are things we do to prevent VAP?
Suction.
Okay, suction them. Huh?
Clean their mouth.
Clean the mouth. Really big one. Clean that mouth. Get that nice clean. I used to make students like brush each other's teeth, just so you can see how not good we are at cleaning people's mouths. Okay. So yeah, that protocol. We want to make sure that mouth is clean. Human mouths are gross, guys. They're just disgusting. This is why I'm not in dental. Like no. My son lost 4 teeth from hockey, and I was like, nope, no thanks. You go to the dentist. Good. Okay. He's a hockey player, so. Went through a lot of years with no lost teeth. We got it this last year. But mouths are gross. We're giving that bacteria a line there. What else do we do for VAP protocols?
Raise the head of the bed.
Raise the head of the bed, yeah. It seems simple, right? Like this is the thing. A lot of our interventions seem really simple, okay? It's because they are. Like it's not complex care. It's just we're anticipating the complications. And so if the tubes are causing sores, move the tube. It's not a hard thought, right? If they've got an infection, risk for infection, let's clean the areas where there's infection. Let's keep the head of the bed appropriate and get them up as needed, okay? One of the things that will help you as you're studying, and I'll find one too, is find a VAP protocol, okay? Find one. And then you can grab a friend, have them find one, have you find one, compare and contrast it. What's the same, what's different, all right? So those are the things that you're gonna be looking at.
I was gonna say, how often do you give the CSG baths? Scrubs?
It depends how stable they are, but usually like 24 hours, like I work night shift, so we did baths on night. So I did a bath almost every night for my patients, but it depends how stable they are. It depends if we think they're gonna get extubated in the morning and that kind of stuff. So yeah, it can kind of depend on stability. We'll get patients that are so unstable we can't turn them. So we go where we know we're gonna get that pressure ulcer, right? But we're just like pressure ulcer or their blood pressure is gonna drop too much. So, okay. So infections, what other complications we got? Huh? Oh yeah. So fluid balance. It's a huge issue. We love to fix things and we love to fix things fast. Sometimes when we give too much fluid, we cause more problem than we can help. So that's one of the things that we're always looking at is that fluid balance. This is why we're gonna draw labs every day on them, if not twice a day, depending on where they're shifting. Okay, and also depends why they're there. All right, so fluid balance becomes a huge issue, especially if we're having pressure issues. Okay, what other complications? DVTs. Yeah, it sucks when we save you and then all of a sudden you throw a clot and you have a pulmonary embolism and now, whoops, right? So what are we doing for DVTs? Huh? TEDs? Okay, TEDs or SEDs?
What about like range of motion?
Yeah, range of motion. Okay, an anticoagulant. So TEDs, SCDs, anticoag. What's our anticoag of choice for these guys? Lovenox. Right, heparin maybe, depending on if the Lovenox, but remember, and you'll get into this when you talk about your blockages and stuff, the difference between a preventative dose and a treatment dose, right? So we use heparin sub-Q 5,000 for a prevention. We use heparin drips when we're treating. Lovenox, we use that little sub-Q maybe once or twice a day, depending on the patient. And if we've got a pulmonary embolism, we're doing high dose Lovenox 2 to 3 times a day. Okay, so thinking about those things. Okay. Any other complications you can think of?
The CLABZ, the central line.
Okay, so yep, going up here, those tubes. Some more of that, the collapsy that we hear about, and then we've got CODIs. Like they love all their like little names and acronyms. It's all infection, right? Clean the area. Okay. One big one that people don't think about a lot is nutrition, right? They're sick. They need nutrition to be able to heal. Okay, so nutrition becomes a big, big deal. Usually, how long do you think we let them go on a ventilator before we start thinking about nutrition? 2 days? Other thoughts? Right away? It's about 24 hours. We'll have patients, right, that we need to wait the 3 days. So again, I'm giving you a whole lot of gray with like some kind of, this is kind of the range, but usually about 24 hours, we're gonna start thinking, we at least need to start thinking, like maybe that day in rounds, we need to start having a conversation with the docs of like, hey, how are we doing nutrition? Are we gonna do some TPN? Are we gonna do some PEG tube? Or some tube feeding? Because here's the deal, if we don't use it, we lose it. So the problem, if you don't use your gut, the gut flows a nice direction, right? Okay, what happens if we don't use it? It flows a different direction, right? So that becomes a really big problem. We have to make sure that we want to use it. We'll do even what they call trickle feed, which just means we're just doing it to keep the gut going the right direction. So you may have them on TPN, right? And they're getting like 40, 60 mLs of tube feed in an hour, blah, 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 right? Like whatever the nutritionist, this is why we love our dietitians and our nutrition people. They tell us what we're doing. We just know why and what we need. And then you may have TPN going, and then you may have like your little bit of trickle feed, tube feeding. It's like 20 mLs an hour. That's not a nutritional dose, right? 20 mLs of tube feed is not going to help us be able to fight off an infection or fight off disease or fight off a traumatic injury. We have to have more food. Okay, so we're gonna probably have to start thinking about it. If we have somebody chilled and cool, they're gonna be cooled for 3 days. You'll probably go into that more specifically with cardiac. We'll sometimes do trickle feed, but when we make everything cold, we slow every system down. So that one kind of depends on what they're doing with them, okay? So thinking about 24 hours is at least when we wanna start having the conversation of like, hey, and the doc may be like, we just did a whole bowel resection on them. We are not putting anything in their stomach. Okay, but you started the conversation. Okay, the doc ultimately obviously decides, but we obviously are the advocates. Okay, and you may do TPN, you may do tube feed. It just depends on what's going on with that patient, but we want to start thinking about that. Okay, all right. So we've talked about some of this stuff. We've talked about complications. We've talked about some of it, but I want to talk a little bit about what types of machines are in the ICU. I love everybody gets silent. You guys have all, like half this group's been in the ICU. What'd you see? Crash carts. So we got crash carts. Crash carts are nicely everywhere. Did everybody locate their crash cart? Okay? Usually the first day I'm on any unit, I go and find where my crash carts are. Big thing about crash carts, unplug the Zoll monitor or whatever monitor you're using. Always hate it when you grab it and run and it goes flying off. I've watched it a couple times. Even at 7 North, we had a couple that this last year when I was there, and people just, that adrenaline gets pumping and they go. I'm like, unplug it, right? You would think they would have like a battery pack thing, that what they would do, but no. So they are durable. That's the nice part, okay? Okay, so crash cart. What else? I heard vent. Absolutely, we got vents. You got vents, you got BiPAPs. We have all sorts of different respiratory driven machines to help us maintain and keep that oxygen status. So you might see a BiPAP, you might see Airvo depending on how stable, heated high flow, stuff like that. So we've got a whole bunch of respiratory machines. Oops, heated, and I use a lot of arrows. Heated high flow, okay. What other things do we see?
ECMO.
Ooh, ECMO. If I never have to see ECMO again, it'll be too soon. Does everybody know what ECMO is? Okay. ECMO is a heart-lung bypass machine. Basically, something's happened where the heart and the lungs have shut down, and so we literally bring your blood out, we oxygenate it in this machine out here, and then we push it back in, okay? ECMO is a very specialized machine. I know we struggled. It became the tool of choice for a while when we were going through a lot of the initial COVID stuff, and then we realized it really wasn't helping people as much as we had hoped. So, but ECMO is a heart-lung bypass machine. If you go like my 9 North friends, if you've got an open heart, they probably were on ECMO down in the OR. Okay, because they can't really work on the heart if it's pumping, you know, and they're replugging things through. Okay, so what about, I said keep it simple, right? IV pumps, we're gonna see lots of them. You're gonna get used to whatever IV pump your facility has, because they all have different ones, okay? There's lots of brands out, and as soon as you get used to that one, I will tell you, they will change. Right? That's just how it works. Like, you're like, yeah, I'm real comfortable with these IV pumps. And now we got these brand new ones. Fantastic. Thanks. Okay. Wound vacs. Yeah. Get some wound vacs on there. See if I have time for a story. I'll do a story real quick. I had a wound vac on a guy. He had been rolled over. He was working on his camper, and the camper had rolled and basically rolled over his groin and like thigh leg area. For everyone, like he left his boys at the scene because they were crushed and he came in and they did a surgery on him. He's like, how do I get to a wound back from here? But they had done surgery on him to remove his leg and to get it all off. He had a wound vac on the hip socket. All of a sudden, I look at a wound vac. What colors should be coming out? What drainage color should come out of a wound vac? Serrasanguinous. Usually pretty small volumes, right? So all of a sudden, the wound vac holds about 500. I put a new canister on. I get bright red blood, and 3 minutes, it's full. Like, well, that's real interesting, right? Pretty sure this is not how this is supposed to be. So I have to put another one on because the dressing's starting to pool with blood and everything. I'm like, okay. So I put another canister on and call the doc. I'm like, hey, I think we've got a problem here. Doc comes in, literally, I love it, in Birkenstocks, jeans, and a t-shirt. He starts pulling down the wound vac dressing. He puts his finger on the femoral artery that is now pumping blood actively and says, I need an OR room, and I need an OR room now. Right? Talk about no sterility, no, like nothing, like at this point. And the guy looked relatively like this. So I am running around. I have my charge nurse calling the OR to get a room. I am unplugging this dude from from all the wall stuff, trying to get respiratory therapy to get him down. Apparently it was just a bloodbath when they got into the OR. I was dumb. I stayed on the floor. If you ever get a chance, go down with that kind of stuff. You're going to see a whole lot. But they had to recauterize the femoral artery, and get it going. But yeah, it was just I was Birkenstocks and jeans, and he's holding this femoral artery pressed down. And I'm like, oh, this is why I wear shoes I can bleach wipe off. So definitely have wound vacs. Sometimes we'll have multiple wound vacs. Wound nurses, again, are amazing resource of information. They are like, if you love crafting, they are like your crafty scrapbookers. They know how to like cut and measure and make things fit. It's so fantastic. You're like, I'm not touching that. There's no way, right? So they're a really good member of the team to help you figure out, especially those wounds, or if you have ostomies that are leaking and all that kind of stuff. They know all the toys. Okay, so we've got crush carts, we've got vents, we've got ECMO, we've got IV pumps, we've got all sorts of I don't know why it likes to switch. We got all sorts of monitors, right? We've got the biz monitors. You'll start seeing ICP monitors if you do head traumas. You'll start seeing, or cranies. You'll see all sorts of Dopplers. You'll see all sorts of things to try and monitor and make everything a number. We like numbers in the ICU. We really like numbers. We write down a lot of numbers. It's really nice now that they all go to the computer. It used to have to all be handwritten.
You're welcome.
So, what? You're welcome. Right.
I do that.
You do that. I like that. I like that. Okay. So other things we could see is CRRT or hemodialysis machines. Okay. CRRT is continuous renal replacement therapy. We'll go into the why and that stuff later on in the term, but know that we'll see those in the ICU. It seems to be which docs prefer it. Some docs really like CRRT. Some docs really don't. So and different facilities and places will get you that. So continuous renal replacement therapy. So, okay. They call it different things at different places too, but we'll go with CRRT. Okay. Because it's like CVHD, it's it's all the same stuff. Okay. All right. So we got all our machines. Kind of went backwards. We knew our complications. All those machines then have tubes that then potentially causes complications of those pressure sores. Okay. Make sure I didn't meet anything. Okay, let's talk about, real quick, let's talk about the types. What are the types of ICUs?
ICU, med-surg ICU.
Yep, trauma, med-surg, neuro, cardiac. There are sick people, cardiac people. That's okay. Neonatal, so we got our NICUs, PICUs, right? We got all sorts of U's. We got all sorts of them. Why do we need different ones? Huh? Specific equipment, yeah. Your cardiac ICUs, they know how to do a lot more of the ECMO stuff. I have done an ECMO patient before. It's not my favorite, but your cardiac ICUs, that they're much more comfortable with that machine. Think about your neonatal intensive cares. Those are your biddies, right? Those little ones, okay? I don't like those ones. Those ones like to crash on you quick. The nice thing is, though, is that babies and kids, they rebound super quick. Versus like your 80-year-olds, they don't like to rebound as quick, but they take a little more time to kind of tank on you, okay? Trauma ICU, gonna have a different focus. There's when I was at the med center, I did trauma. It was trauma/liver ICU, so we got a lot of the liver recoveries from transplant team and stuff like that. So neuro, that's a lot of our heads, strokes, those kinds of things. Okay, there's different levels within them. The med center is a level 1. Is it Bergen?
Bergen's a level 1.
Bergen's the other level 1. Okay. The thing with level 1s is you usually have 2 level 1s in one area because you have to be able to interchange. They have to have doctors on staff all the time. So when stuff goes down, there has to be a doctor on site. Level 2s don't have to have a doctor on site. They have to have a doctor within 20 minutes or so. Okay. So it just really depends. And residents count as doctors. So that's why the teaching hospitals a lot of times are your level 1s. Okay. So your level 1s, when Lindsay was talking about the mass casualty stuff, I don't know if all you guys remember Von Mar. That was a long time ago now. I was working at the Med Center ICU during the Von Mar shooting. We didn't have a procedure for mass casualty events at that time. And so it was between us and Creighton, and there was just a whole lot of confusion and a whole lot of mess. We didn't get a lot of patients from that. Most of them that came to us did okay. The other ones, they didn't make it to us. So, but now most places have mass casualty things. And I will tell you, you think mass casualty events don't happen here, they do. I've been involved now with Bon Mar, and then we had a mass casualty shooting in Crete, Nebraska. Probably didn't get a lot of news because it's Crete, where someone went in and shot up a lunchroom. So we've had mass casualty events here. So if for all the people like, oh, it can't happen here. Oh yeah, it can. So people get angry.
We just avoided one a couple weeks ago.
Right, the Target one.
I
Yeah.
was actually in that parking lot. It was not.
Yeah.
Fun fact on the radio this morning, they were talking about the 3 most dangerous jobs, and teaching was number 3.
Yeah.
Because of all the school shootings.
Yeah. Yay.
Isn't that crazy?
Well, Mexico's dangerous, right? Good. So we all have our issues, right? Right. Teaching has become a real interesting one. The other thing that they're starting to do. So just a side note. The other thing they're starting to do is most of our shooters were kids going through shooting drills, so they know what the practice is for shooting drills. So now they know how to plan around it. I tell my kids, just this is personal, but I tell my kids, if the fire alarm goes off and you do not smell smoke and you do not think that there is a fire, you stay in your classroom. And or you get, because what a lot of shooters do is they pull the fire alarm to get people in the hallway and get the chaos. So that's where a lot of casualties have come from. So I tell them, I'm like, nope. The last school fire that killed someone was in 1866. So this is the rabbit holes I go. No one wants to be in this brain, okay? So, right? Okay, anyway, so, but there's different types. There's different levels within those types. NICU, I don't know. We'll have to ask Amy later. NICU, I feel like does it different. It's backwards. I'm like, really? Like, why can't we do the same? But yeah, so NICU level 1 is like their most stable, and their level 3 is their craziest. I don't know why they had to do different.
Isn't women's like a level 3 for NICUs?
I don't know.
Yeah, I know.
Wait,
they're-
that'd be a
they're
really,
like high acuity.
really good to ask Amy when she comes in. Like I said, I don't do those little bitty bodies.
Yeah, women's
So,
is 3 though.
is it a 3?
And children's is the only one.
Okay, so 4. They go up to 4. Yeah, we just have 1, 2, and 3, I think, and then like critical access hospitals. So, okay, so those are our types. We know we're going to use them at some point. Let's talk about real quick. Let's talk about this piece because, okay, when it comes to family, right, they are going to be at the bedside. They are going to be seeing all these numbers, all these monitors, all these things. How do you help them? Okay, explain. How are you going to explain it to them? Okay, so tell me what that means, right? Like you guys all like,
You can say that like for the vent, instead of saying the vent, you can say this one's helping them breathe.
okay,
This one's giving them fluids.
okay,
This one's
keep it simple, right? What if they're an ICU nurse somewhere else,
Oh, you can throw all the terms out.
right? So here's the thing. You adjust to what your patient and family needs. And that's one of those things, like when we talked about in 300, that back pocket question of what do you know about your dad's care, right? If it's like, what do you know about your dad's care? I just know he's hooked up to a lot of tubes and wires, and I don't know, right? We're in the feeling fog. We're not going to have a real good conversation about medical dialogue. If they're like, oh, well, I know we've been here for 3 days. I know they're talking about a trach. I know the pressors we've been okay to come down on a little bit, right? Very different conversation. So what you want to do is you want to adapt to their level, okay?
I'd also caveat if they'll probably say, I'm an RN or I'm in health.
Yeah.
Well, don't just stop there because where,
Right.
and you don't want to insult them, but at the same time, a lot of times they'll be like, you let me know if I'm giving you too much or too little.
Mm-hmm.
Like, put it back on them so that they don't feel like they have to take on the burden because they're trying to be a family member at that time.
Right.
And they may not have gaps.
Yeah.
So.
So the other thing is like, yeah, ask them like when somebody's like, well, I'm a nurse. Fantastic. Where are you a nurse at? Right? Where do you do nursing? Oh, I do mental health. Oh my gosh, that's awesome. We need so many good mental health nurses. I'm going to explain to you at a very different level than if somebody's like, I do life flight, you know, on the helicopter. That's a different level, right? They already know at least the names of the drugs. Now, if they're in complete shock, doesn't matter. Like, we go back to those real simple language. Even if they're like, yeah, I'm a nurse, I do life flight, but this is my dad, and I'm freaking out. Okay, let's get you through, right? This is where that therapeutic, oh man, I really spelled that one bad. Therapeutic, don't give a dyslexic. That's probably, there's an R somewhere, right? Okay, I get the letters in there, but not necessarily in the right order. You know what I mean, right?
Yeah.
This is why I let you do our own notes, okay? Don't give a dyslexic a pen and paper. But, so, therapeutic conversations, right? Meeting them where they are, body language matching. We did that day in 300. You're going to see that. You're going to want to be that, right? Because it doesn't matter what's going on the monitors and stuff. Like, there will be a ton of beeps going on. I can look at it. I assess that it's stable, even though it's beeping. I might silence them. As students, do not silence alarms. Come get one of us. I don't want you guys getting in trouble for silencing something that shouldn't have been. Let us be the ones to tell you to silence it, okay? Use our experience and our plunges to know what we can do. But, like, meeting them where they are. If there are beeps going on, it's going to be really hard to have a therapeutic conversation, just because those beeps just cause anxiety. They cause anxiety in me, and I've been in the room a ton of times, right? So I always, I'm a silencer, but you guys don't silence. We want to make sure, like I said, we meet them where they are. I know this is the big one for anticipatory grieving. Okay, and this doesn't mean that the person is necessarily dying, but it does mean that, like, my dad just had a massive stroke. He's not going to be able to work the farm, right? My son just got in a car wreck. Is he ever going to be able to go back to school? You know, stuff like that. So you're not just grieving the end of life process. You're also grieving the life they knew. Okay, and so that's the stuff that we have to always pay attention to, is that, like, oh my God, they're the breadwinner, and I don't know the bank account passcode, right? Like, there's all sorts of processes going on, especially when they're in this state. Hopefully they've had conversations with their loved ones about how far they want to go in this, but I'm gonna tell you, very, very often they have not. All right, so we're gonna have to work with that grieving process. And what is one of the first things that we get with grief? Denial and anger. I always think, like, ICU sucks for that reason. Like, we get a lot of anger. Like, the rehab nurses, they get the excitement of watching them walk again and all that kind of stuff. ICU nurses, we get a lot of that denial. No, they're fine. They're fine. I'm gonna tell you too, especially like with our head traumas, a lot of times all that's on our head traumas is a bruise on the back of the head. And they look perfectly fine otherwise. And so that can cause a lot of problems. When people see the bruises and the stuff, then they understand it. But when we only have, like, it's hard to see. Like, you don't know, like, okay, he's sick, he's got a lot of tubes hooked to him, but I don't know why. I can't tell that he's in renal failure from just looking at him, right? So that's one of the things that gets really challenging with our patients as well. Okay. All right. So we've talked about the family. Now what about us? How do we take care of us and the team? Is alcohol an appropriate fixer? It might be a good stabilizer for the moment, but it is not a fixer for the permanent. Here is the thing. If you decide that ICU is your jam and you love it, find your people, right? Because we have to support one another. ICU nurses and ER nurses and a lot of this, they have like a PTSD with working in these environments, because you do get a lot of this sadness, you do get a lot of this, the anger and all of that, but you also see people in the worst moments of their life. Sometimes you get to see the cool stuff. Sometimes you get to you see them come back, or you get to see them look better and get better. But honestly, usually once we stabilize them enough they can push their call light, we're shipping them out, right? We don't like call lights. You shouldn't be able to push it. If you can push it, go. Okay? That means you're good. That means you're healthy, right? That means you're getting better. Okay? It's not a jerk move. It's an evaluation where you're at, right? But for us, we need to make sure we're taking care of each other. We also need to make sure we are honest. I needed to leave the ICU. I knew I needed to leave the ICU, and I did, right? Like, I knew I was coming home. Like, probably one of the biggest kickers was, like, my kids were talking. Kids always give you the honest reflection, right? Kid was talking and said, well, Mom, all people are stupid. And I'm like, oh my God, why would you say that? And they go, because you say that every morning you come home from work. I'm like, oh, that's the lens I look through, right? I'm a trauma nurse. People don't go to, they'll be honest, people don't usually come to a trauma ICU because they made the best decisions. All right, so they didn't wear a seatbelt, they had tried to outrun a train, they played with a gun, they took a handful of pills, whatever it is, right? They don't usually come to a trauma ICU specifically because they made real good decisions. Some people do. Those ones cut, right? Those ones hurt because you watched a mom that was driving home from work and she got sideswiped by a semi, right? Just bad luck. Okay, so we do see that, and we have to be able to go home to that because I can't go home and tell my kids that I just watched someone pass away or whatever. Like, those are the things that we always have to pay attention to, and we got to take care of each other. If you got someone you can recognize and built that relationship, and you're like, you're not doing so hot, I'm going to give you this patient, right? The other thing we do is when we're doing reports, so like people on 7 North got to see that everybody kind of got report, and then they picked their patients. The nice thing about that is, like, I know there was a time we had a 13-year-old girl in our trauma ICU. She was a head injury and was gonna go into organ donation, and I have a 12-year-old at home. Okay, I chose not to take that patient. Right, I got to say, I'm gonna step this one out. Right? So I actually switched with the charge nurse. I became the charge nurse and she took the patient, right? But if I hadn't had that relationship, I couldn't have been in a safe space to say, you know, that's just not the patient I can take. I'll be honest, I struggle now taking suicide patients, where before I took them all the time. I struggle now taking them because I've had 2 nephews die by suicide. So now it's just a little bit more of a tender spot for me. And if I'm having a bad day, I'll tell you that now. So if we're at 7 North and something triggers me and you see me like off in the corner crying, you can put your hand on my back. It's okay. But like that might be. There's something that just was like, okay, right? We have to allow ourselves to be human as well. All right, and we have to do it. So make sure if this is the route you go, even if it's med surge, let's just be honest, support each other. Right? Sometimes we are just the nitpickiest people on each other. We're human too. So make sure we take just as good of care of our patients as we take care of ourselves and our team. So the last thing that I want to cover, let's see, did perfect. Okay. This sounds really dumb, but what's the goal of ICU care? Not necessarily stabilization. ER does that, right? Let's keep them alive. Remember, I like simple. This is the name of my volleyball team. Keep them alive to 7:45. That was always fun. Okay. But our goal for ICU care is to keep them alive. And with that goal, that is why we do everything we do. If they're not breathing, we breathe for them. If they don't have a blood pressure, we're going to help them get a blood pressure, right? If they're not peeing, we're going to figure out the science behind why they're not peeing, and we're going to either give them Lasix, give them albumin and fluids, whatever it is, we're going to put them on CRRT, whatever we need to do, we want to make sure we keep them alive, all right? And I will tell you, the definition of alive in ICU is a heartbeat that you can actually feel, pulse, right? Not just what the electrical rhythm has, because there is an electrical rhythm called pulseless electrical activity, PEA. That is not alive. That's not a heartbeat, right? Heartbeat is a pulse we can feel, and breathing can be on the ventilator, right? So that is the definition of alive in the ICU, right? The definition changes depending where you go. So keep them alive. That's our goal. Everything we do, all the machines we have, go to that. Okay? Any questions or thoughts? It's a pretty cool environment.
I just have a question, because they have so many tubes and you obviously don't want to move them too much. So when it comes to like changing them, for example, how does that work?
We roll them all the way on their side.
Okay.
You have friends, right? You bring in your friends. You're like, hey, Like, I think we had a guy that was like 400 pounds or so the other day, and it was like, okay, how many people can we bring in to help us do it? And that's when you'll plan. You'll be like, hey, I know they just had a bowel movement. We need to get them cleaned up. Do you guys want to finish with your 2 or 3 patients, and then we'll go to, this room and work with this person. So yeah, you have somebody that's usually, especially when we were proning people a lot, that was a challenge when we prone people. You would have, somebody's usually always managing the airway, right? Watching the ventilator, the airway tubes. Somebody's usually watching all the other tubes, but we're all talking to each other too. Because somebody may have the arm behind the bed or behind like a pillow or something, and they don't see it, and be like, hey, I'm moving the arm. Oop, I've got their art line tubing. Like, we very much are very verbal to each other so we can hear what other people are doing when we do it. So yeah, depending on what's going on. The ones we don't turn is if when we turn them, their pressures drop in tank, or all of a sudden their O2 sats drop because we turned them. They're usually, if some of them are that unstable, we'll have to, sometimes we get the rotating beds. Those are nice if we can get those. And the bed will just kind of slowly rotate them from side to side. You just have to make sure you have extra tubing so that it doesn't pull. But yeah, so those are nice beds. We used to have, this is so dumb, we used to have beds that had a hatch underneath the bottom, and we would go and like you'd have to crawl under the bed and like take down the hatch. Dude, I did this. It was so bad. They were like, you're the little one, here you go. Right? I was like, no. And so you'd have to pull down this hatch, and your butt would hopefully be there, but it never was, so it never really worked out. But so we would try that. But yeah, our goal, keep them alive. That's all our stuff. Okay? Any other questions? That's a great one. Your thoughts? Should we take a quick 5-minute break, and then we'll get into some we'll kind of do some wrap up some more ventilator stuff?